All right, so let's move on to our next esophageal functional disorder. 16-year-old with a history of dysphagia with solid food, getting worse over the last year. He has to drink 2 20-ounce beverages with each meal. Endoscopy was grossly normal with 1 eosinophil per high power field in the distal esophagus. And the patient takes no other medicines other than Motrin for migraines. So what testing would you do? Would you do an upper GI series, a flip, high resolution manometry, or no further testing needed? And we'll talk about the options here. So functional swallowing disorders, Rome has two, the Rome diagnosis has 2, globus and functional dysphagia. The criteria are here on the screen. I'm not going to talk about globus today. I'm really going to focus on functional dysphagia because this is where really testing has changed our understanding of this disorder. With a sense of food getting stuck, these patients feel that food is stuck. They don't have any mucosal abnormalities. There's no reflux. There's no EOE. And then there's an absence of a major esophageal motor disorder. And I think this is where the really interesting next steps are going to be from a science perspective. So just to show you a tracing from a patient of ours with functional dysphagia, again, just looking at the high resolution manometry. So the reason we do high resolution manometry in these patients is we really need to rule out achalasia. We really need to rule out scleroderma. And so these, just like for the esophageal reflux functional diagnoses where we're recommending early testing, similar here for the dysphagia patients. So really we're relying heavily on testing to make the functional diagnosis. Your upper esophageal sphincter is here. You can see the patient swallows. You see a peristaltic wave coming down. You actually see multiple peristaltic waves coming down. And if you look at this, you would say this patient clearly has peristalsis. This is not an achalasia-like picture. Your lower esophageal sphincter is opening when given a liquid swallow, but maybe the peristalsis is a bit weak. The DCIs may be a little bit low. When you superimpose impedance onto these tracings, remember pink is where there's liquid. You can see the patient is swallowing liquid, the pink goes down, but you still have pink hanging around in the upper esophagus. You have pink hanging around in the middle esophagus. You even have some pink pooling over the lower esophageal sphincter. So this is a really good example of how, yes, you may have peristalsis, but is it functional? This patient, based on their high resolution manometry, would be given a diagnosis of functional dysphagia, but I would argue that their function is not so great of their esophagus. And this is more complex than just saying that they're feeling things getting stuck when you don't see anything. If you didn't pair it with impedance, you would have said that the motility was okay.